Welcome back, doctors. Today we are breaking down one of the most high yield topics in the pediatrics, the pediatric cardiology. We will be discussing the conceptual part of it. In this video, we will be talking about fetal circulation versus newborn circulation, the term PVR and SVR, shunts, the right to left shunt, left to right shunt, shunt reversal, and plethoric and oligemic lung fields. Also, stick around till the very end because I'll be dropping a couple of clinical questions for you to solve based on what we learned today. Let's dive straight in. Fetal circulation. I've prepared a very simplified diagram to understand the fetal circulation. So we have a placenta, liver, heart, and lungs here. Starting with the placenta, we all know it's a connection between the mother and the baby. Nutrients are passed on to the baby, excretory products are secreted from the baby, and most importantly for us here is the purification of blood that occurs in placenta too. Placenta has umbilical vessels. We have two arteries and one vein. Just like pulmonary artery and pulmonary vein, umbilical artery and umbilical vein are also opposite. So the umbilical vein carries the oxygenated blood to the baby and umbilical artery carries the deoxygenated blood from the baby. Then this umbilical vein reaches the liver where it gives a small branch called the portal vein, and the majority of this oxygen-rich blood bypasses the liver as ductus venosus, finally draining into the IVC. IVC, just like us adults, carries deoxygenated blood from the lower body of the baby, and SVC carries the deoxygenated blood from the upper body. When umbilical vein drains into the IVC, the mixing of blood happens and then this blood goes into the right atrium. Out of it, some goes into the left atrium via the foramen ovale, a physiological opening in the heart of baby, and most of the blood from the right atrium goes into the right ventricle. And then blood travels via the pulmonary artery, and instead of going to the lungs, it travels via ductus arteriosus into the aorta and then to the whole body. Lungs are non-functional in babies, so pulmonary vascular resistance, which is the resistance offered by the pulmonary vessels like pulmonary artery, is very high, and thus we say high PVR so that the blood refrains from entering the lungs. Similarly, so as to allow the blood to enter the systemic circulation, the aorta, the systemic resistance is kept low, and thus we say low SVR, so that the blood from the pulmonary artery can directly enter into the aorta. So basically, mixed blood is now flowing into the baby's body. From the aorta, blood travels all the way down, and then internal iliac artery gives out branches, including branches of umbilical artery, which then carries this mixed blood to the placenta, and the cycle continues. Once the baby is born, baby gives a good cry, takes a breath, and eventually the lungs expand. The lungs becomes functional. The oxygen acts as a potent vasodilator and ductus arteriosus closes because there is a flip of resistance in PVR and SVR. That is low PVR and high SVR causes this shunt to close, and just like adults, blood purifies in lungs. Eventually, after some time, foramen ovale also closes. So the deoxygenated blood entering via IVC and SVC into the RA and then into RV, that is right ventricle, enters the pulmonary artery and then to the lungs. From there, the pulmonary vein carries the oxygenated blood to the left atrium and left ventricle and finally into the aorta and to the whole body. Also in fetus, the ductus arteriosus is open and the blood flows from the right side of the heart to the left side of the heart, and this is physiological or normal. That is from the right ventricle and pulmonary artery on the right to the aorta on the left. So this is a right to left shunt. Just keep this point in mind. We will be needing it later. Moving on to the shunts, we will be starting with left to right shunt, so it's easier to understand the right to left. We all know left side of the heart is high pressure compared to the right side, which is low pressure. So if there is any opening between the two sides, the blood will flow from the high to low pressure, that is from left to right. This is exactly what happens in ASD, VSD and PDA. AST is nothing but an opening in the atriums of the two sides, VST is opening in the ventricles of the two sides, and PDA is the open ductus arteriosus after birth. We talked about the right to left shunt in ductus arteriosus, which was before the birth and it was completely physiological. But if after birth the ductus arteriosus doesn't close, we call it patent ductus arteriosus. Patent meaning open. So in that case, we have left to right shunt. I hope this point is crystal clear for you guys. Now, if blood flows from left to right, that is, in case of ASD, left atrium to right atrium, there is an overload of blood in the right atrium and right ventricle. So, clinically, if we see right atrium and ventricle enlargement, it is ASD. In VSD, the left ventricle to right ventricle. So there is overload of blood in right ventricle, but this blood is eventually moved into the lungs for purification and overload occurs in left atrium and left ventricle. So clinically, if there is left atrium and left ventricle enlargement, it is VSD. In PDA, from aorta to the pulmonary artery, there is overload of blood in lungs which is then again moved to the left atrium and left ventricle. So clinically again we have enlarged left atrium and left ventricle. But since this blood is also entering the aorta again, we also see the aortic enlargement and aortic knuckle. This is what differentiates PDA from the VSD. Also a point to note. Sometimes VSD can be large enough to cause the blood overload in the right ventricle, causing right ventricular enlargement. Now, in all of these conditions, we see more blood flowing towards the pulmonary artery. That means it is a plethoric lung field. And because purification of blood is occurring even after the shunting of blood, so these are acyanotic conditions too. After some time, due to increase in the pulmonary artery blood overload, the pulmonary hypertension occurs and there is a shunt reversal. This phenomena is called as Eisenmenger syndrome. So the blood which was flowing from left to right starts to flow right to left. The mechanism we will discuss in the next section. Right to left shunts. We have pulmonary stenosis, tricuspid stenosis, tetralogy of Fallot, and Ebstein's anomaly. Pulmonary stenosis. Stenosis meaning narrowing of the pulmonary artery, so the blood cannot flow properly and hence there is overload of blood on the right side. This defect is always accompanied by an ESD or a PFO, that is patent foramen ovale. The pressure eventually surpasses the high pressure on left side and we have right to left shunt, that is the blood starts flowing from the right side of the heart to the left side of the heart. Tricuspid stenosis. Similarly, there is a narrow passage from tricuspid valve and hence blood cannot really pass the right atrium and overload occurs. The pressure in the right atrium increases which surpasses the left side and this defect is always accompanied by some ESD or PFO through which blood is shunted from right to left side. Tetralogy of Fallot. We have classic 4 components in tetralogy of Fallot. VSD, the ventricular septal defect. PES, the pulmonary stenosis, overriding of aorta, and the RVH, the right ventricular hypertension. Pulmonary stenosis along with the large VSD causes the shunting of blood from right to left as discussed previously. Ebstein's anomaly. Again, the patient has some ESD or PFO. In Ebstein's anomaly, the tricuspid valve is situated at lower side and it's floppy too. So right ventricle is always loaded accompanied by the tricuspid regurgitation which increases the pressure and eventually we have right to left shunts. In all of the conditions that we discussed above, there is mixing of deoxygenated blood with oxygenated blood which cannot be purified and is supplied to the whole body. So most of these conditions when accompanied by an ASD, PFO or a VSD which causes the mixing of the blood, they become the cyanotic conditions, but there are always exceptions. Also, in all of these conditions, the blood is moving away from the pulmonary artery, so they are oligemic lung fields, but again we have exceptions. That's a wrap up of all the high yield concepts of the neonatal cardiology for today. Before you go, I have a clinical scenario based questions for you to solve. Pause, think about the answer, and put your answers in the comment section below. I'll be dropping up a follow up video very soon answering each question in detail. If today's video streamlined your concepts, hit that subscribe button and check the channel for answer drops super soon. Keep studying and keep working hard for your dreams. This is Dr. Prachi signing off. See you in the next one.